Welcome everybody to the session. Session today is caring for people who use opioids and how to get started. I'm Fernando. I'm one of the physicians with the Fraser Health Addictions Medicine and Substance Use Service teams. I work in the Rapid Access Clinic. That's where I am right now currently. I also do an Oak Clinic in Langley and Chilliwack and a family practice in Abbotsford as well. So I'm just going to move on to our learning objectives for today. So number one is to describe the primary care practices for treating opioid use disorder, including wraparound supports and providing continuity of care. Number two is to describe the benefits associated with opiate agonist treatment. Number three, to identify the opiate agonist treatment options available in BC. And number four, to identify steps to becoming an OAT prescriber in BC. So we'll start with a timeline here. And so in 1908, policy was rooted in anti-Chinese racism, and opioids went from being accessible at pharmacies to being highly criminalized and stigmatized. In 1950, medicine becomes a more prestigious profession, and recognition that modern medicine could be used to care for people with substance use disorders. Instead of solely relying on criminalization, Dr. Lawrence Ranta had two recommendations. The first would be a call for rehabilitation centers for people who use drugs. And number two is there is advocacy for a provincial narcotics clinics where people could receive maintenance treatment. But 8 years later, in 1958, the first methadone program in Canada opened in Vancouver to treat withdrawal symptoms from morphine or heroin. And it later provides maintenance treatment. And this was pioneered by Dr. Robert Halliday. 1999, the provision of opioid agonist treatment in Canada is passed from the federal government to the provincial government. And that brings us to more present day, where we're going to discuss OAT options in British Columbia. There's multiple types of OAT that are available to people with opioid use disorder that can be accessed at clinics and pharmacies in BC. Evidence-based OAT is the standard of care for opioid use disorder in BC, and we'll be discussing evidence-based OAT options today. So to set the context of the importance of OAT, opiate use disorder is associated with social and health-related harms, overall morbidity and mortality, co-occurring medical conditions, mental health impacts. In BC, and it's a staggering number, 14,629 people have died due to the drug toxicity since the declaration of the drug toxicity crisis in 2016. This supersedes homicides, suicides, motor vehicle collisions combined. These are 14,629 people who are loved ones, family, friends, coworkers, neighbors, community members, and not just numbers. And just want us to take a moment to just kind of contextualize that and think about what that number really is. If we move forward to the next slide, it shows us a graphic representation, a visualization of the public health consequences due to the increasingly volatile and toxic unregulated drug supply. This data was taken from the BC Coroner Service and showing unregulated drug deaths in BC from their webpage. And so the increase of deaths is largely driven by the increasingly toxic unregulated drug supply, primarily being fentanyl. And when we say toxic, it's also contaminated with multiple other substances. So there could be benzodiazepines, or you may have heard in the news things like tranq being added to the drug supply. There have been 572 deaths in the first 3 months of 2024. And this is why today we're going to be talking about opiate agonist treatment, as it's highly effective and can really save lives. The goal of today's presentation is to encourage primary care providers to think about how opioid use disorder can be incorporated into their practice. People with opioid use disorder are often referred to specialists or rapid access clinics, like the one I'm in today, to receive opioid use disorder care. But there's some risk associated with this. So these referrals, you can have people fall through, and there's a risk of lost care, or there's a lack of continuity as well. Primary care is the ideal setting to manage opioid use disorder for many people. It's built on existing trusting relationships. Individuals are already receiving care there, and it allows you for that longitudinal care piece, which is so important. And then you can collaboratively develop care plans to manage opioid use disorder along with other primary care pieces longitudinally. And so when we think about this, we really want to emphasize person-centered opioid use disorder care. And primary care providers should be able to share information about all services and programs that are available. And the next slide will cover the best practices in opioid use disorder. So the traditional approach for opioid use treatment was it used to be acute short-term inpatient treatment. As an example, that could be a patient in the emergency department for a withdrawal program with not much follow-up after discharge. However, opioid use disorder is recognized as a chronic relapsing condition best suited for longitudinal care. And so the pre-existing relationships and establishing consistent relationships with care providers provides more support for treatment engagement and retention. And so we want to try and manage this in an outpatient setting when possible. A referral to a specialist can still be appropriate in certain circumstances, and our team, for example, is more than happy to help. But if people are able to provide it in the primary care setting, that's also very beneficial for the patients. Physicians, nurses, midwives, pharmacists, as well as all people providing care in First Nation communities can use the BCCSU's 24/7 clinician support line that runs 365 days a year, and they can consult with an addiction specialist if needing extra support. There's also extra support for physicians and nurse practitioners who can use the rapid access to consultative medicine, which is the RACE line, as there are specialists available for consult there as well. We also want to emphasize wraparound approaches, as you can see in the third box there. We want to have a holistic approach that includes healthcare, which would be primary care, wound care, mental health care, and services beyond healthcare, such as housing services, legal services, educational, vocational support, to really center on the client's needs and preferences. And lastly, there's a comprehensive health management. So we want to screen for and manage co-occurring conditions, which can be very common, such as substance use disorders, mental health disorders, opioid use, injection-related sequelae, preventative health care, sexual reproductive health services, chronic disease management, and we want to ensure fully functioning referral pathways when connecting specialists and services. We can have conversations about safer drug use. That would be something like a take-home naloxone kit that you can offer to patients, or at least a resource that could get them that resource. Referral to other harm reduction services should be routinely offered as part of the standard care for individuals with opioid use disorder. So the continuum of opioid use disorder care, as you can see in this diagram here, I'll try and go through some of the pieces. It includes screening and diagnosis. There's going to be pharmacological treatment and intervention, and that will be using opioid agonist treatment for the standard of care, and we'll be going through that today. There's withdrawal management, but withdrawal management alone, without transition to OAT, we wouldn't recommend, as if you're only managing withdrawal and not providing something for the person to use ongoing, you might just be lowering their tolerance by managing withdrawal alone, which could lead to more problems like overdose in the future. There's psychosocial interventions and supports, which we can routinely offer to our patients. And these interventions and support should be offered in conjunction with the pharmacological treatment. Peer support as well is something that can be beneficial to our patients, and harm reduction programs and services are also part of this continuum. Individuals may need to try different approaches along this continuum as their needs and circumstances and goals change. So to talk about opiate agonist treatment and the benefits of OAT, which will just be on the next slide, you can see here that OAT increases treatment retention and protects you from non-fatal and fatal drug overdoses or poisoning. And then it also reduces unregulated opioid use, helps reduce opioid cravings, reduces the overall risk of morbidity and mortality associated with unregulated opioid use, and reduced injection risk behaviors amongst people who inject drugs. For example, methadone treatment is also linked to better adherence to antiretroviral therapy among HIV positive individuals. Now, opioid agonist therapy and primary care is the next slide here. And this is just a little bit, I guess I can explain a little bit about my own practice and how that relates. So I have a family medicine clinic in Abbotsford, and I also do an OAT clinic in Langley and Chilliwack. And if someone were to take this on in their clinic, I'd recommend a couple key resources. One, the urine drug screen is a really helpful piece to help ensure like safe care and proper care for our patients, and then access to PharmaNet. So it's not a lot of resources that you need to be able to provide this care in your clinic, but with those two basic pieces, you can provide fairly like well-informed care there. Of course, you'd have to chat with your patient and find out more about their circumstances. Some benefits that I've seen is, I mean, I've had patients see me with, for example, hepatitis C that has been untreated for years, and then finally connecting with a primary care provider, we're able to call the clinic that can offer Hep C treatment, and they're sending outreach workers to see them in the community now. And so that person who wanted to access the treatment for so long was finally able to, because we could focus a little bit on primary care. I have patients with like who were recently diagnosed with metastatic colon cancer who went to a hospital, had treatments for like basically a brain operation, and then were sent out the door with no follow-up. And I really wonder why something like that could happen. But that person, I took them on into my family practice and said, like, you're someone who needs like longitudinal care here, not just treatment for your opioid use disorder. And so they're stabilized now on OAT, and now they're able to focus and spend their time on accessing the cancer care treatments that they do need. When I've had patients with rheumatoid arthritis, for example, who have really severe untreated chronic rheumatoid arthritis, and they use their hands actively. That's something that they use for their job, and they're unable to perform that job because of how severe their arthritis is. And for the first time in many years, we were able to have a conversation and say, you know what, there are treatments for rheumatoid arthritis. We can probably get this under control. You don't have to rely only on opioids to manage that. And finally, they're able to connect. And so I think there's like tremendous benefits to providing primary care in conjunction with opioid use disorder. And it's something that if we can have more clinicians and more providers who can follow a patient longitudinally, it really just helps overall that patient access better care. There's going to be underlying medical conditions that are often associated with opioid use disorder, such as anxiety and depression, PTSD, chronic pain, infectious diseases like Hep C we were talking about, or HIV or bacterial infections. And having a primary care provider is so essential to managing all these other pieces. Oftentimes with the opioid, like the OAT clinics or the rapid access clinics, they're limited in terms of how much longitudinal care they can provide in terms of like other primary care disorders. And so this is why we're having the session today, to see if we can encourage more people to pick up this much needed work. So moving forward into the regular benefit options in BC. And so today's presentation is going to focus on OAT and opioid use disorder. And opioid agonist treatment is the standard of care for opioid use disorder. All the options listed here are oral options, with the exception of injectable extended release buprenorphine, as you can see in like the first little top left column there. It's a visual representation here of the OAT options that we're going to be covering today. And so this diagram shows us the options covered as regular benefits for opioid use disorder treatment by BC pharmacare plans. And at the bottom, you'll see plans B, C, G, and Z. If we start at the top corner there, buprenorphine-based formulations, there's two main formulations. And it's a large word. Buprenorphine naloxone is a big mouthful, and especially for me too. So I might refer to this as Suboxone. That's what you'll more commonly hear it as. So they're interchangeable. You basically have injectable extended release buprenorphine called Sublocade, and then you have buprenorphine naloxone tablets known as Suboxone. You also have on the second block there, you have methadone, and there's a few different formulations of methadone. There's methadose, there's Metadol D, and we haven't listed it here, but there is a compounded methadone that can be covered by a special authority. However, most of the time, we're probably able to use methadone or methadose or Metadol D. It's very rare to see anyone really use compounded methadone, but it does exist. And the third option that we'll be chatting about today is slow-release oral morphine. And just, sorry, before I continue, I just want to mention for methadone, there is a sugar-free option as well, in case that's something that is important for your patient in terms of like sugar control. So then moving on to the third block is slow-release oral morphine, also better known as Cadian. And this is a 24-hour slow-release oral morphine. And so individuals can be offered buprenorphine naloxone or Suboxone. They can be offered methadone or slow-release oral morphine or Cadian based on the person's circumstances, goals, and previous treatment experience. Although we are not discussing injectable OAT today, injectable OAT is an option for treating those with severe opioid use disorder who have not benefited from oral OAT. And injectable OAT would be something using hydromorphone or diacetylmorphine or heroin, in a sense. So we'll talk a little bit more in depth about, on the next slide, for buprenorphine, naloxone, or Suboxone. And after this, we'll talk about the other formulations as well. And so just to note, MDs and nurse practitioners do not need to complete, there's a course called the POT-SP course, which we'll be talking about later as how to better learn, study, and qualify for prescribing OAT. But when it comes to Suboxone, in this case, buprenorphine naloxone, you don't have to complete that course. That's something that you can prescribe right now without any further training. Sorry, there we go. Sorry, my computer ended for a second there. Okay, where are we here? Okay, so Suboxone is provided as a sublingual tablet. You'll see the combination of like a 4:1 ratio with buprenorphine to naloxone. Buprenorphine is a partial opioid agonist. Naloxone is an opioid antagonist to deter injection and insufflation of tablets. So if you were to inject or insufflate these tablets, it would likely precipitate withdrawal as the naloxone component would be active. But if you were to take the tablets sublingually as directed, the naloxone has almost no effect as this medication has very poor bioavailability sublingually. So you see them, it comes as different formulations. There's a 2 milligram tablet. There's also an 8 milligram tablet. That's how we would commonly refer to them. There is the naloxone component in both of them, but 2 milligram and 8 milligram tablets are the types of and sizes of tablets that we use. And they can be broken into smaller components as needed for our patients. Moving on to the next piece, we'll talk a little bit about the safety profile and like the side effects associated with Suboxone. So Suboxone has a superior safety profile compared to methadone and Cadian. And Suboxone should be considered the favorable option in the absence of individual circumstances that favor other options. There's a low drug poisoning risk due to its ceiling effect, where the effect of other opioids are blocked. And so part of that ceiling effect is because, as we mentioned, this is a partial agonist. And so if you were to bind all the receptors in somebody's body and with a full agonist, it might cause respiratory depression due to too much activation there. Now, Suboxone being a partial agonist, even if you were to bind all these receptors, there's a limit to how much respiratory depression that can cause, and we refer to that as part of the ceiling effect. So it's a much safer medication to be taking. There's a mild side effect profile, very few drug-drug interactions, and it's suitable for immediate take-home dosing. This is different from other forms where immediately it's a little more difficult to have take-home dosing, but Suboxone being a little safer, we can provide that. So if you're an MD or a nurse practitioner and you want to start prescribing Suboxone, you could do so immediately. And if you need any extra support or help and want someone to help guide you through that, the BCCSU 24/7 clinician support line is happy to help. And same with the RACE app is another resource you can use for some extra support. We'll talk a little bit about extended release buprenorphine, or the injectable form of buprenorphine. This is also commonly known as Sublocade. And so it comes as a monthly injection that goes subcutaneously into the abdomen. It comes as 300 milligram or 100 milligram formulations. Normally, when you start somebody, you give them the first dose as 300 milligrams, and then a month later, the second dose as 300 milligrams. Following those first two doses, you can then reduce it to 100 milligrams monthly. Those first two are just the loading doses, and then you can maintain on 100 milligrams. In some circumstances, some people do continue on 300 milligrams. But if that's the case, I'd probably have a chat with the BCCSU 24/7 line or the RACE clinicians just to run those cases by. This is medication that's administered by physicians, nurse practitioners, nurses, pharmacists. It's indicated for adults with moderate to severe opioid use disorder. And it does require you to have some stabilization on the oral tablets of buprenorphine naloxone first. And so the product monograph indicates that individuals should be stabilized on a dose of at least 8 milligrams of Suboxone for at least 7 days prior to induction. However, individuals stabilized on doses higher than 24 milligrams or those for less than 7 days, you could still consider it. But that's outside of the product monograph in that indication. The reason for this is because you want to prove that it works. You want to prove efficacy. You want to prove that these tablets, which you can stop a tablet at any time and transition to another OAT if needed, you want to prove that these tablets work because The worst case scenario is you transition someone to a long-acting injectable, and it's not a medication that works for that person, and you can't really go back on that. And so this is why we want to see somebody having about 7 days of stability on the oral tablets before we transition them to the injection, because then we can feel confident that this injection is going to work very well for them. The next slide, we'll talk about methadone. So in contrast to Suboxone, which is a partial opioid agonist, this is a full opioid agonist, and it's taken as an oral solution once a day. And it takes several days to reach a steady state, which is a very important concept to understand for methadone. And because it takes several days to reach a steady state concentration, it takes several days to reach that maximum therapeutic effect. But that also means that it takes several days for you to see any delayed emergence of like serious adverse side effects, like respiratory depression, that can be associated with a dose that's too strong. And so this is why we titrate it a little more slowly and give people at least a few days before we would change the doses. This is all something that would also be covered within the POT-SP courses. There is no maximum dose prescribed or described in the product monograph. And in the new guidelines, the BCCSU guidelines, it's saying individuals may require doses greater than 150 milligrams a day. I think that's a fair ballpark. It all depends on the person and the individual, and it can be less, it can be more. But I think that's not a bad ballpark to have in mind, just so that there's some reference. Moving forward, there's the other option of Cadian or slow-release oral morphine. Again, another full opioid agonist. It's widely prescribed for pain management, but increasingly being used in opioid use disorder care and is one of the options that I routinely would discuss with patients. You administer this as a once-a-day oral capsule, and you'd probably take multiple capsules as the dose increases. It's a 24-hour release, and so the goal is for someone to take that capsule or take their dose and be comfortable all the way until their next dose 24 hours later. Again, no maximum dose is described in the monograph, and doses for a ballpark, maybe about 1,200 milligrams or more. These numbers are usually in reference to people who are using fentanyl. And so if you're not using fentanyl, if you're using a weaker opioid, you may not need doses that high. So these numbers are in reference likely to fentanyl considerations. Now, those were the three main options, and now we'll talk a little bit about how to become an OAT prescriber. And so there is an education pathway. And so I'll break it up for physicians and nurse practitioners, and then for RNs and RPNs. And so for MDs and nurse practitioners, right now, Suboxone or buprenorphine naloxone, you can prescribe that right now. But if you want to expand to methadone, Cadian, to those other oral OAT options, if you want to expand to extended release Suboxone or Sublocade or injectable OAT, you can take the POT-SP course. There's also a separate pathway for RNs and RPNs that will allow them to prescribe Suboxone, methadone, Cadian, and this is currently being worked on by the BCCSU to expand that to Sublocade, the extended release buprenorphine as well. MDs and nurse practitioners and RNs and RPNs will take two different POT-SP courses, and the POT-SP course is the main course you will take, and these courses are tailored for the roles. And then you are provided a workbook. And so the overall process is the same. You would do your course online, which is a fantastic course. You would then get a workbook, and that workbook would have different cases inside of it. And then you would work with an in-person preceptor, and there's a list of preceptors online that can be identified throughout different regions where you can work with that preceptor, ask questions about the workbook, and then also spend some time with actual cases and actual people. And then if you can work with that preceptor, they'll give you some mentorship there. And so to become a prescriber, number one, to know like completing the online course alone doesn't enable you to prescribe these medications. You do need to do all pieces. So the workbook will have those scenarios that you need to do, and the preceptorship is also needed. Let me see here. So in summary here, so adults with opioid use disorder should be offered OAT as the standard of care. And OAT prescribing in primary care is ideal, as we were touching upon why, because it's longitudinal, it's built on those existing trusting relationships. How can we do this? I mean, right now, if you're listening to this and you're an MD or a nurse practitioner who's not prescribing, you could start with Suboxone today. And I would definitely recommend you do call like the BCCSU line or the race line just for some support. If it's your first time, right? Definitely no shame in that at all. And I would recommend that. And then opioid use disorder does not always necessitate referrals, and you can incorporate that into your primary care. Of course, we're very happy to help with any referrals that come our way and to provide any support needed. We want to support individuals across the continuum of care by ensuring this continuity of care and the availability of wraparound services, like we were saying. There's the importance of social services, housing, food, sexual health, and legal services. And I know that's a lot. I know that sometimes that's not always available in the clinic itself, but within the health authorities, there are clinics that can provide more of these resources. And so we want to encourage you to complete the discipline-specific educational pathway, starting with that POD-SP course to become an OP prescriber. The link to the POD-SP course is going to be in the resources section at the end of the presentation. There's a little QR code there that I think that will link to that. And then a reminder that NP and NPs, you don't have to complete that course to prescribe this box, and you could start that today. So that wraps up most of the presentation that we have here. And then I'll hand it back to the team to carry on.